Good morning, everyone. I'll be briefly presenting the management of traumatic brain injury. Before starting, I would welcome all of you to ISACON 2021, and I would like to thank the organizers for giving me an opportunity to be a part of this academic event. The main aim of my today's talk would be to summarize the best practices for management of a patient with severe traumatic brain injury based on the evidence-based medicine. Traumatic brain injury, as we know, is a global problem. We have around 50 million people injured every year, and unfortunately in India, we lose 1 out of 6 trauma victims. If we see the head injury as we classify it on the Glasgow Coma scale, where mild, moderate, and severe. The severe head injury being classified as a patient who has a GCS of less than 8. Then we have classification of head injury as primary injury and secondary injury, with the primary injury which is produced by the direct mechanical impact, which may be diffuse brain injury or a focal brain injury, which may manifest in the form of a contusion, epidural, subdural, and intracerebral hematoma. The secondary brain injury, as all of us have been taught, it develops within minutes to hours, and the main cause for the secondary brain injury is as a result of respiratory dysfunction or a cardiovascular instability, and it's coupled with an increase in the intracranial pressure. The main things that we need to keep in mind while managing a patient of head injury are how to resuscitate such patients, how to maintain their blood pressure and oxygenation, which osmotherapic agents should be used, should we go for hypothermia, should we prescribe antiseizure prophylaxis, can we hyperventilate such patients, when to go for decompressive craniectomy, how do we achieve their glucose control, and once we operate these patients, is there any particular anesthetic technique that we need to follow? These are some of the things that we'll discuss in the subsequent minutes. Fluid resuscitation, once we do it in severe head injury patients, we need to remember that isotonic crystalloids, they are the preferred fluids. So hypertonic fluids, hypertonic crystalloids, they are now being increasingly used. Once we have such a patient with intact blood-brain barrier, we need to remember that it's the osmotic pressure that is the primary determinant of the fluid movement in such patients. But once we have a total disruption of the blood-brain barrier, this selectivity is lost, and the hydrostatic pressure, it becomes the primary determinant of the fluid movement. However, the situation becomes very complex once we have a partial disruption of the blood-brain barrier. So we feel we have enough evidence that it's better to save fluids that increase the plasma osmotic and oncotic pressures rather than to infuse those fluids that decrease the plasma osmotic and oncotic pressures. That's the hypotonic fluids. We should at the same time remember that once we use hypertonic fluids for resuscitation, smaller volumes may be needed, and they may have a better effect on increase in mean arterial pressure and a better improvement with the cerebral perfusion pressure. However, once these results were put into clinical trials, there was one clinical trial published in 2010 where the hypertonic saline and normal saline were compared. It was seen that the hypertonic saline did not translate into better neurological outcomes. Similarly, in SAFE study, once albumin, it was compared to crystalloids, it was seen that albumin exacerbated the neurological outcome was poor in those patients who received albumin, and probably it was because of the exacerbation of the vasogenic edema. Similarly, in the CHAS trial, the colloids, they were compared with crystalloids, and it was seen that patients who received colloids, they had a greater need for the renal replacement therapy. The second caveat that we'll discuss is the optimization of the cerebrovascular hemodynamics. It was way back in 1977, it was realized that elevated intracranial pressure, it is an independent predictor of poor outcome in patients with severe traumatic brain injury. So we should take steps to avoid increase in intracranial pressure to greater than 22 millimeters of mercury. It was Saul, Ducker, and Miller who realized in 1980s that an increase in intracranial pressure would increase the mortality significantly. There's a direct relationship between the two. And also a landmark study that was published by Martin, it showed that on the first day of injury, the blood flow to a patient with severe traumatic brain injury is the least because of the elevated cerebral blood flow velocities. Based on these theoretical approaches, two approaches are followed for the treatment of head injury. We have the ICP targeted approach, where emphasis is laid on keeping the ICP below 22 to 25 millimeters of mercury, and the cerebral perfusion pressure, where we lay emphasis to maintain the cerebral perfusion pressure above 50 to 70 millimeters of mercury. To achieve all these goals, we follow a step ladder pattern where we sedate the patient, go for CSF drainage, administer high mannitol, and sometimes we go for mild hyperventilation if these measures are not successful, and then we may go for barbiturate coma, hypothermia, decompressive craniectomy in patients who have a refractory increase in intracranial pressure. The cerebral perfusion pressure management, once it was discussed in detail, it was analyzed by over a period of years, we have started to understand that there may be two approaches. It may be a Rosner's concept, where we maintain a cerebral perfusion pressure greater than 70, or the Lund concept, where the cerebral perfusion pressure is maintained greater than 50 millimeters of mercury. From the Rosner's concept, study showed that the mortality was around 29% once we use this Rosner's concept, and similarly once we use the Lund concept, the mortality was 8% once it was compared with the historical controls of 47%. However, so far there is no randomized control trial between the two groups that could have led us to conclusive results. However, the Brain Trauma Foundation guidelines, which were published in 2000, they favored the cerebral perfusion pressure targeted approach and recommended that CPP, it should be maintained greater than 70 millimeters of mercury. But after this, there were two studies. One was published in Critical Care Medicine in 1999, which showed that once we keep cerebral perfusion pressure above 70, there's an increased incidence of ARDS. And in the second study, which was done on a post hoc analysis of patients in which N-methyl D-aspartate antagonist was compared for head injury patients, it was seen that once the cerebral perfusion pressure is less than 60 millimeters of mercury, the outcome is poor in such patients. So based on these findings, the Brain Trauma Foundation, they revised their guidelines and they advised that the cerebral perfusion pressure should be between 60 and 70 millimeters of mercury. However, if we see the recent evidence, we have a better understanding that probably it's not a unitary value that's important. We have to have an individualized approach to cerebral perfusion pressure. So with the advent of the transcranial Doppler and its increased use into the clinical practice, we have now two types of patients: pressure active, which respond better to hypertensive therapy, and pressure passive, which respond better to hypotensive ICP oriented therapy. Microdialysis, which has a limited evidence in the clinical scenario as of now, but in coming years it may help us to define these targets in a better way. Hyperventilation is defined as a carbon dioxide level of less than 35 millimeters of mercury, and it reduces the intracranial pressure. Carbon dioxide reactivity is preserved following traumatic brain injury. That's very important caveat to remember. And at the same time, we have to remember that though hyperventilation, it may reduce the intracranial pressure, at the same time, it decreases the cerebral blood flow, thereby worsening the cerebral ischemia. A landmark study was published in 2002, and it was seen that once we hyperventilate the patients and the correlates were analyzed in hyperventilated patients on positron emission tomography, it was seen that the hyperventilated patients, they had a hypoperfusion. There was a severe ischemia and a decreased cerebral perfusion pressure. So, based on these findings, the Brain Trauma Foundation recommended that prophylactic hyperventilation, that's carbon dioxide less than 35 millimeters of mercury, should be avoided during the first 24 hours. However, still acute hyperventilation has some role in patients who have an acute neurological deterioration, or if we are in the process of transporting these patients to a definitive center, we may practice hyperventilation once for very brief periods once there are signs of impending herniation. The other caveat we need to understand is about the osmotherapy. We do not have any class 1 studies that have compared the efficacy of either mannitol or hypertonic saline with placebo for ICP reduction. So we have class 2 and class 3 evidence that suggests that both are effective. However, we do not know which osmotherapeutic agent is superior, at what doses it should be used, or whether osmotherapy really improves the outcome in severe traumatic brain injury. It has been seen that once we give mannitol, it may be helpful by decreasing the blood viscosity and improving the rheological properties of the blood. So doses from 0.5 gram to 1.5 gram per kg have been used in clinical practice. And mannitol use has been at the same time found to be associated with electrolyte disturbances and acute renal failure once it's used for protracted period, and rebound phenomena, that's a paradoxical increase in ICP, has been also seen with mannitol use. There are few trials that have tried to address the efficacy of mannitol, and one trial found that once mannitol it was compared with the barbiturates, there was a better control of the ICP and improved outcomes. Similarly, there were 3 trials that compared the high dose mannitol versus conventional doses of mannitol, and it was seen that there was a better neurological outcome at 6 months once the high dose mannitol was compared with the conventional doses. Hypertonic saline has been again found to be beneficial like mannitol, and it has been seen that once we use hypertonic saline, there is an added advantage that it is less likely to cause a rebound cerebral edema, and it has the added advantage of a decreased leukocyte adhesion, and it even modulates the inflammatory response to the head injury. There are some studies that have tried to address the issue whether mannitol is better or hypertonic saline is better, and it has been seen that the treatment failure is more with mannitol group once we compare it with the hypertonic saline. So if we summarize, we have class 2 and class 3 evidence that both mannitol and hypertonic saline, they decrease the intracranial pressure, but we do not have adequate data as what are the optimal doses for the treatment for both. At the same time, we have theoretical advantage that favors the usage of the hypertonic saline over mannitol. Now coming to the cerebrospinal fluid drainage. The current Brain Trauma Foundation guidelines lay down that the cerebrospinal fluid drainage should be done in patients who have a Glasgow Coma scale less than 8 or age greater than 80 years, motor posturing, or systolic blood pressure less than 90. If we have two or more of these features, we should go for the cerebrospinal fluid drainage. At the same time, it has been seen that once we go for the cerebrospinal fluid drainage, there are two types of cerebrospinal fluid drainage that we can use in clinical practice. We can go for a continuous or an intermittent cerebrospinal fluid drainage. It has been seen that if we go for a continuous cerebrospinal fluid drainage, it may be associated with collapse of the ventricle, which may in the long run lead to a blockage of the catheter. At the same time, we can even have infection or ventriculostomy associated hematomas once there is a rapid drainage of the cerebrospinal fluid. Barbiturates have been used for cerebral protection in patients where we have a refractory increase in ICP barbiturates. They are believed to cause a dose-dependent depression of the neuronal activity with reduction of the cerebral metabolic rate. There are certain studies that have tried to see the efficacy of the barbiturates, and once barbiturates they were compared with mannitol, the barbiturates they did not offer any additional benefit over mannitol. Also, it was seen that hypotension was more common in the barbiturate group. It was most of these studies they were conducted in the early part of the 20th century or late part of early part of the 21st century or late 1990s, and it was at that point of time the effect of barbiturates was very poorly understood. However, still we do not have a conclusive evidence to support the prophylactic use of high dose barbiturates that could lead to the conclusions that barbiturates are helpful in the treatment of severe head injury patients. We do not have any evidence that barbiturates are really helpful. They have been helpful in improving the neurological outcome. If we see the guidelines from the traumatic brain injury, we have level 2B evidence that administration of barbiturates to induce burst suppression measured by EEG as prophylaxis against the development of intracranial hypertension is not recommended. However, if we use high-dose barbiturates, it's recommended to control elevated ICP refractory to the maximal standard and to the standard medical and surgical treatment. But at the same time, we should maintain the hemodynamic stability in such patients. The hemodynamic stability, it should not be compromised in such patients. Decompressive craniectomy is being increasingly performed worldwide. But unfortunately, again, we do not have much evidence, though it's believed that decompressive craniectomy, it reduces the volume constraints on the cerebral compartment. If we see the complications of decompressive craniectomy, the long-term complications, we have the development of a subdural hygroma. There may be infection of the bone flap or there may be even fracture of the cranioplasty. There's a huge literature supporting decompressive craniectomy and a huge body of literature opposing it. There are two trials, the DECRA trial and the Rescue ICP trial, which have been published recently. DECRA trial has shown unfavorable functional outcomes at 6 months, and similarly, Rescue ICP trial has not shown favorable results. It has been shown from the Rescue ICP trial that the patients who underwent decompressive craniectomy did not transform into an independent living. So we do not have enough evidence to support a level 1 recommendation. Hypothermia again has been practiced in severe head injury, but unfortunately we have not had encouraging results. A landmark study that was published in NEJM showed harmful effects of hypothermia, and then a lot of work on hypothermia was done which showed varied results, both beneficial and not beneficial effects of hypothermia. But Shiozaki found that hypothermia, though it may not be helpful in patients who have mild increase in ICP, but it may be helpful in uncontrolled ICP. The beneficial effects may be more in patients with uncontrolled ICP once we compare it with mild ICP. And again, it may be more helpful in focal lesions and patients who have a midline shift. Recently, we have the polar RCT trial, which does not really show encouraging results. So if we see the traumatic brain injury guidelines, again, from the pooled data, we have that the prophylactic hypothermia, it's not associated with a decreased mortality once we compare it with the normal patients. Glucose control, we have to have euglycemia and a target blood glucose of 140 to 180 milligrams per deciliter has been advocated. Intensive insulin therapy may be harmful in severe traumatic brain injury. Antiseizure prophylaxis, if we see the recommendations, we have prophylactic use of Mannitol or valproate is not recommended for preventing late post-traumatic seizures. Nitrous oxide use is controversial in head injury patients as both opponents as well as proponents. But if we see the long-term effects of nitrous oxide in head injury patients, nitrous oxide can be safely used in head injury patients. It has been a time-tested friend for all of the anesthesiologists. Similarly, there have been various trials that have compared the inhalational and the intravenous anesthesia, but there is no advantage of one trial over the other. So if we summarize all the lecture, we do not have any conclusive evidence that is of the class 1 that could support the use of any therapies. Task force was appointed by the American Association of Neurological Surgeons, and they found the ineffectiveness of 3 long-standing management practices. That's the use of steroids, anticonvulsants, and chronic hyperventilation. For rest of the recommendations that we have discussed, they are entirely based on class 2 and class 3 evidence. But at the same time, it has been also seen that once we use these recommendations, these class 2 and class 3 recommendations, they have improved the outcomes significantly once we compare it with the historical controls. Thank you. Thanks a lot.